Dear friends, today I am going to discuss the technique of percutaneous screw fixation for lateral condyle fracture in children. This 4-year-old male fell on an outstretched hand while playing Lateral. This was his injury film, which shows slightly displaced, that is conventionally described type 2 fracture of lateral condyle with olecranon and displaced fracture. The child was put on a plaster, and then 1 week later there was increase in the gap. And along with olecranon fracture, we decided to investigate further. In internal oblique view, we could easily see that this was a type 3 Song's fracture. I would describe what Song classification is. According to Song classification, if there is a gap which is same as laterally as well as medially and less than 2 millimeter, it is called as a type 3 fracture. And according to Dr. Song, one needs to close, reduce and fix it either by percutaneous pinning or screw. Here, because of the additional olecranon fracture, I use percutaneous screw fixation. The fracture can be compressed by flexion and pronation of the elbow, and percutaneous pins can be passed in this position. To pass the KY, first we need to put it freely over the skin and see which is the best entry point. And once we confirm the best entry point, the KY, here I am using 2.5 millimeter KY, is passed percutaneously and kept at the site of the entry. Once the KY is seen perfectly at the entry point, one need to mount a drill on that. One should confirm in multiple views and then mount the drill so that we can immediately start drilling the fracture. Drive the KY and monitor the progress of KY in all the views after passing and make necessary adjustments. Assessments and adjustments are always necessary while passing the KY so that we do not make multiple tracks. Once the final position is satisfied, remove the drill. The KY progression can be seen here in multiple OrthoTV images. Please confirm in lateral as well as internal oblique view. Once everything is confirmed, take a small incision for the screw insertion. The incision then can be dissected down to the bone with the help of hemostat. Once that is done, pass the sleeve over this 2.5 millimeter K-wire and then remove the K-wire. From the same track, replace the K-wire with a guide pin. Once the guide pin is in place, confirm whether the guide pin has gone in the same track or not. These are the X-ray view showing perfect guide pin placement. After confirmation, take the measurement for the screw and then simply pass a 4 millimeter cannulated cancellous screw over the guide pin because we have already drilled the track with 2.5 millimeter K-wire. Hence, no separate drilling is required for passage of the 4 millimeter cannulated cancellous screw. The final tightening preferably should be done in a flexion pronation view, which is more important for cross K-wire or a divergent K-wire rather than for a percutaneous screw, which would compress the fracture site as shown by this maneuver. This is the progression of the screw in various views. Final tightening and compression is done, and then the guide pin is removed and closure is done. The gap, you can see the gap closure here by the compression of the screw. I always do arthrography to confirm the articular congruity, which is seen beautifully here. The child is then placed in plaster for 3 weeks because we want to mobilize the child early. At 3 weeks, plaster is removed, and 1 month X-ray shows excellent union, which is best appreciated by internal optic. The screw can be removed at 6 months easily as an OPD procedure. We thank you for watching this video. For more videos such, you can subscribe my channel. Thank you very much once again.